So I'm Anita Hedlund from the Family Childbirth Center.
I'm Rebecca Swanson.
In the fall, I'll have been at Ballard for 15 years. And next month I'll be 20 years as a nurse. So I'm going to talk about preterm labor, rupture of membranes and labor, and then Rebecca's got the bottom stuff. Yeah, so jump right into it. So, preterm labor is defined as cervical change or effacement and uterine contractions that occur between 20 and 36 weeks of pregnancy. There are many risk factors for preterm labor, which is the first page of your pink handout, and notice how many your patient population has. I guess I need a copy to look at.
Here, I'll you take this for now, and then I'll go.
So, history of a preterm birth. Many of the CUPS ladies have had preterm births before. They can certainly have hypertension. They may be malnourished and have low pre-pregnancy weight. They may be obese, which is just in the general population, more obesity, right? Later, no prenatal care, ding. Smoking, ding. Alcohol, ding. Use of illicit drugs, double ding. Domestic violence, lack of social support, stress. Non-white, or primarily if they're of a non-Hispanic black race, they're at the highest risk for preterm labor. But basically, if they're non-white, they have higher risk. An age of 17 or greater than 35, and low socioeconomic status. So they have all these things when they walk in the door. And then some people, it's just there's a genetic component, so that's, we don't know ahead of time. And then probably the biggest one for you guys to pay attention to in the immediate setting is, do they have some kind of infection going on? So if you think about the physiology of a pregnant woman, they've got this big distended uterus, which is now the largest muscle in their body. But the bladder's right there and the bowel is right there. So if they have a UTI and their bladder is irritated and spasming, that's going to affect the uterus. If they have stuff going on with their bowels, which CUPS ladies do, they all are either constipated or having diarrhea because of their withdrawal, that affects their uterus as well. If they're having, abdominal cramps or they're constipated, that all feeds into the activity of the uterus. So any of those things, UTI, dehydration, and things going on with the bowel can make them contract. Because that's probably their number one complaint, right? I'm contracting or I'm in pain. Short interpregnancy intervals, so they might have just had a baby 12 months ago and now they're big pregnant again, so their uterus is seeing a lot of activity without a lot of rest, downtime. Fetal anomalies are actually pretty rare, even in women that are using illicit drugs. Premature rupture of membranes, which we'll talk about. Vaginal bleeding, and then another big one for your population is periodontal disease. If they've been living on the streets, and they can very well come in with bad gums and teeth, and as you know, that can lead to like endocarditis and stuff. So the diagnosis is they're between 20 and 36 weeks. They have contractions that are documented, and their cervix is changing. So they either get checked by the physicians, or they have ultrasounds that show that their cervix is shortened, and then that their cervix is documented to be changing or is more than 1 centimeter dilated. So the big question is, how do we tell the difference between preterm labor contractions and plain old Braxton Hicks type contractions? It says on your handout that Braxton Hicks was named after a doctor named John Braxton Hicks, who first described them in 1872. So that's where they got that weird name from. So Braxton Hicks contractions generally are just tight. Like the mom may not notice them. They might come over for an NST. We might put them on the monitor, and we might see that they're contracting, and they don't even know. Some of them can rest their hand on their belly and feel that it's getting tight, but it's not painful. It's just tight, or pressure. That's typical. But if they start feeling crampy or they are in pain, that is a big red flag to me that those type of contractions might be actually changing the cervix, if there's pain associated with it. So if your patient says, I'm contracting, the first question is, how often? Can you sit down and look at the clock and say, I'm having one every 10 minutes? Swedish discharge instructions for people that come in, say for monitoring, and then we send them back home. They should call if they're less than 37 weeks and they have 6 to 8 contractions in an hour. So if your patient is noticing them that frequently, you definitely need to alert the physician. Being dehydrated, activity, and infections, as I mentioned before, can cause contractions. If she says they have regularity, have her time them. And then have her lay down, kind of hydrate herself, drink some water. And if they don't go away or space apart or get less intense after an hour, notify your physician.
Empty your bladder too.
And have her empty her bladder, yeah. So, symptoms of preterm labor, as opposed to just the garden variety Braxton Hicks that anybody with a stretched out uterus can have. Again, if they feel crampy, so labor usually starts as they feel it very down low, way down over their bladder area, like menstrual cramps, and or back pain, like low back pain. Somebody in the first session said, well, our patients often complain of backache, and partly because of the hospital beds. How do you know if it's just a general backache or if it's labor backache? Labor backache is usually down very low over the sacrum, as opposed to up in the lumbar area. An increase or change in vaginal discharge. As their body is getting ready to give birth, their natural kind of mucus discharge is going to increase. So if they're saying, oh, it's just wet down there, I don't know what's going on. Obviously, feeling that the baby is pushing down, you'd want to get that checked out. And abdominal cramping with or without diarrhea, because again, the bowel and the uterus are right next to each other, and what one does affects the other. And then again, that frequency of contractions. So some patients, especially if they have had children before, they're aka multips, multipara, para meaning birth. So if they've had many births, they've been stretched out many times, and it just does that low-level twitching. So I think of it as kind of, it's just doing these little twangy, small contractions. So there's a lay community website called irritableuterus.com for people that just contract and they don't know why. The ultimate cause of irritable uterus is unknown. No research has been conducted. Based on their anecdotal reports, the most commonly reported triggers are activities such as lifting heavy things, walking, standing, exercising, having orgasm, and then health-related issues such as your patient's dehydration, full bladder, stress, UTI, and constipation can all trigger uterine irritability. Some of them reported that wearing tight pants and being out of shape may also cause uterine irritability. So as you well know, constipation is a big issue for CUPS ladies because most of them are on narcotic. I've noticed that they like to drink a lot of coffee, and I don't know how much water they're drinking, so encourage more water and less caffeine. There's kind of this issue out there that a woman's water can break at any time, whether or not they're in labor. And I used to wonder, before I had children myself, why pregnant women were always mistaking and weren't sure if their water broke or not. I'm like, why do they all think their water's broken and it's not? It does occur, they say in the literature, 10% of pregnancies. I feel like it's a bit higher than that. But when I was pregnant myself, I found out that in the late third trimester, it becomes very damp in the perineal area. You're sweaty. Your body increases that natural discharge because kind of like I think of like lubricating the body, and that discharge, the mucousy stuff, can actually become thinner and more watery. It's not water, but it's watery, and they probably are going to have to start wearing like a panty liner or something. The difference with if it's their amniotic fluid leaking is that it's going to be fairly continuous, like they're probably just going to feel it coming out fairly regularly, and they're going to need to wear a pad, and the pad is going to get wet. If they have any show, any pink mixed in with the fluid, or pelvic pressure, they need to let somebody know. So what will happen if your patient says, I think I'm leaking my water, is you're going to send them over to the childbirth center. There's basically two ways to diagnose it. One is sort of a soft call, which is nitrazine paper. If it is their amniotic fluid and we touch some nitrazine paper either to their pad or to them, and it turns dark, dark blue, that tends, plus they have what we call a good story, you know, like I heard it pop and it ran down my leg and it made a puddle on the floor, you know, that's pretty obvious. If they're not sure, if they're like, you know, well, maybe my bladder's leaking, that is possible, but it's not going to leak over and over every 10 minutes over an hour, right? So the definitive way to prove that it is amniotic fluid is the provider does a speculum exam. They look up around the cervix for pooling of fluid, and then they can nitrazine that and or put some of it on a slide. When amniotic fluid dries on the slide, it creates a crystallized pattern, and that's called a fern, and that's why it's called the fern test. Does it dry into a fern or not? And then that's looked at under the microscope. The nitrazine is a soft call because it can be falsely changed by other substances like blood. So, pooling of fluid. The other day I had a patient, she, you know, just a regular patient, and she came in and she wasn't sure, and her story to me wasn't that good. I was kind of doubting that it was her water. I thought it was probably just that increased normal discharge. But when the provider put the speculum up, she pulled it out really fast, and I thought, oh, she was going to readjust it to try to see the cervix, but the water was just pouring out of the cup of the speculum. So I was like, well, that's pretty obvious. That's her water. Sometimes moms don't know because it's such a slow leak, and they might go for, say, a routine ultrasound at some point in their pregnancy, and they'll discover that the amniotic fluid is low, but that would be a more rare case. And there's a lot of fluid in there, half a liter to a full liter. And when it's coming out, it seems like 5 liters to the mom because it's kind of uncomfortable. It feels like you're peeing yourself and you can't stop. So we talked about this, that it is hard to tell what's coming out because there's watery discharge, and then it could be actually their amniotic water. So usually they will need to wear a pad if it is their water. And it has a very unique smell. If you've never smelled it, the closest thing we can equate it to is semen, because they both have those prostaglandins in it. So labor, true labor, I don't like to call it, they have the terminology false labor. I prefer to call it pre-labor because we don't want to discount what's happening to them. It's going to be false. It's more like their body's warming up. So they can have periods of regular contractions, especially if they've had babies before, but they decrease in frequency if they rest, they're spaced apart. They may have discomfort down low. Activity doesn't change the contractions though, and they'll go away with sleep, and then their cervix doesn't change. With true labor, their contractions are going to get longer, stronger, and closer together over time. They're going to get more intense. They may feel it down low as menstrual cramps. They may feel it in their back, but it usually radiates, you know, will start feeling like a band all the way around their abdomen. Sleeping doesn't make the labor go away. And then if they're checked, say at 1 p.m. and they're 1 centimeter, and then the doctor rechecks them at 3 and they've changed, then they're making cervical progress and they are in labor. And of course at that point, with the current setup, they would be transferred out. And bloody show is normal. That can be anything from a little spot or just pinkish. And that's because the cervix is very vascular, and that's the little capillaries breaking in the cervix as cervical change is happening. If your patient has gone in for a routine OB visit and their cervix has been checked, they might see a little bit of old blood from their cervix having been touched. But fresh red blood is concerning, and that's what Rebecca's going to talk about.
And there's another chair here if someone's here, so I'll be. Here. Okay. So hypertensive disorders in pregnancy. I'm going to talk about the three ways that those can manifest: chronic hypertension, gestational hypertension, and preeclampsia. Oh, and I'm Rebecca Swanson. I work in labor and delivery. I worked at First Hills perinatal labor delivery for 7 years, and I've been here since December. So going back to this, hypertensive disorders in pregnancy is one of the leading causes of maternal death. So that's sort of on the very kind of end of it. But when they look at poor outcomes for moms, it's usually somehow they can trace it back down to some sort of hypertensive disorder that might have had a contributing factor. So first of all, there's chronic hypertension. And chronic hypertension, the definition is that it was present and observable before the pregnancy started. So this is someone who was hypertensive before they even got pregnant. It's usually diagnosed before 20 weeks gestation. And the systolic is equal to or greater than, I just couldn't put the number down below the little sign, 140, and then diastolic greater to or equal to 90. And even a chronic hypertensive person has an increased risk of abruption because of the higher pressure that's happening. And then there's gestational hypertension, and this is a new onset hypertension. It's usually found after 20 weeks gestation, and the same numbers as far as the systolic and diastolic. And this term, gestational hypertension, is supposed to replace the term PIH, pregnancy-induced hypertension. The diagnosis is usually retrospective because with gestational hypertension, it should then resolve by 12 weeks postpartum. So if it's still there, then we're looking probably at a more chronic hypertensive person. And there can be overlay with chronic hypertension versus preeclampsia and gestational hypertension, and with overlaying preeclampsia. So it's all kind of can become muddled, but these are the main definitions. And with any type of hypertension, we need to be aware of considering how to best keep oxygenation and perfusion to the fetus. And then finally, preeclampsia. And preeclampsia is gestational hypertension plus proteinuria in a previously normal hypertensive woman. Preeclampsia can be classified as mild, severe, and it can progress to a really, really severe syndrome, such as the HELP syndrome or eclampsia, which is seizures. HELP syndrome is hemolysis, elevated liver enzymes, and low platelets, and that's a pretty serious situation that they would obviously be in L&D at that point. If there's not any proteinuria, but the patient is complaining of headache, blurred vision or spots or stars before their eyes, abdominal pain that's sort of upper right quadrant, right under the right breast, that's kind of could be indicative of like a liver involvement, and abnormal labs if they had liver enzymes and creatinine and some other kidney functions that are kind of off, then to be really keep investigating, keep an eye on, keep assessing. The considerations that nurses want to make is this patient will be at a risk for abruption, stroke, vascular accidents, liver and renal problems, and the fetus is at risk for abruption, IUGR, and not receiving what it needs from the placenta, because that placenta is not going to be the best placenta in a preeclampsia situation. Risk factors for preeclampsia is a first pregnancy or a pregnancy with a new partner. So if a mom is having her third baby, but it's the first time with a different partner, then she's at a risk for this as well. Multiple gestation, pre-existing disease states, so gestational diabetics, just diabetics in general, chronic hypertensive people are at high risk for developing preeclampsia, maternal age, African American race, history of it, my mom had it, my aunt had it, Antiphospholipid syndrome is a rare syndrome that puts you at risk for preeclampsia. Obesity, insulin resistance. So you can see that a lot of the CUPS ladies have some of these risk factors or more than one. So the best way to keep your eye on a hypertensive situation is with accurate and consistent blood pressure assessments. And when I rotated to ARS, it looks like the ladies get their blood pressure done in the morning, at night, sitting in the chair, and so that's a consistent way of doing it. Arm at pretty much heart level, rather than sometimes laying on her side, sometimes standing up, sometimes sitting down. That wouldn't be the best consistent. So I think like the process that you do it in is pretty consistent. This will allow you to see subtle changes over time, and make sure that cuff is appropriate. If you need to have a couple of different size cuffs on there to get a good reading, would be appropriate, especially if she's sort of borderline. Is there edema? Like, did she look fine yesterday and all of a sudden today her face looks really puffy and her hands, she's complaining that her hands feel swollen? That would be something to take extra note of. And does she have protein in her urine? Deep tendon reflexes, those would be good things to investigate if some of these other things are coming up. She looks puffy and swollen, she's having some high blood pressure readings, she's complaining of spots in her eyes. Then to check reflexes and see if she's really brisk would be another assessment tool that might be helpful. This is from Swedish, our values from our website, so that you can look these up at any point, hypertension and pregnancy. Here's normal pregnancy values, and here's changes that you would see in someone that's going towards preeclampsia or in a preeclamptic state. So hematocrit increases, platelets decrease. Those are kind of the big ones. Creatinine, this is a measure of kidney function. And then the liver, that's kind of a later, it's probably progressed a little bit if the kidney and the liver is already involved. So just for a reference, I never hard time remembering. I always have to pull it up. Sure. So this is IUGR, intrauterine growth restriction, and this can be happen if someone has hypertensive disorder in pregnancy, because the placenta is not feeding that fetus very well if it's under constant pressure. So lots of times gestational hypertension, chronic hypertension, or a preeclamptic person might have an issue with a small growth restricted baby. There's a definition, and the source for it. Risk factors we just talked about: hypertensive disorders in pregnancy, placental problems, and that'll be because the baby's just not getting the nutrients that it needs. Alcohol abuse, substance abuse, poor nutrition, and smoking. So lots of your ladies have these risk factors as well for having a small baby or growth restricted baby. And fundal height is a measurement from the pubic bone to the top of the growing uterus or fundus, and it goes with the amount of weeks. Like, so 20 weeks gestation, they should have 20 centimeters of growth, and so on and so forth. And so if they're starting to measure behind, a provider would probably order some ultrasounds, and the baby would be checked up on with some more serial ultrasounds. Okay, bleeding. So placenta previa, the definition, sorry for not having it up there, I'll tell it to you, is when the placenta implants and covers the cervix, either completely covers the cervix, or partially covers the cervix, or is just a little too close, low-lying for comfort. And so that's the problem. The mom is going to be at risk for bleeding if that cervix starts to change and open. The first thing that's there is the placenta. That can't be delivered first. So this is a high-risk situation when someone's placenta previa. This is kind of blurry, but you can kind of see complete is the placenta's right over the birth canal, and then marginal and low line. Now sometimes this will be found on like a 20-week ultrasound, and then it'll resolve as that uterus and everything grows. The placenta kind of gets to a better location, and it can be no problem by 35 weeks or whatever. Then it can be a history of having a previa, but not current. So this is something that is an important thing for L&D to know. Was there a previa? Is there a current previa? Do we have a good ultrasound that says that there's no placenta covering the cervix anymore? Risk factors are previa, that puts you set up for having it again. Prior C-sections, and the more C-sections you have, the higher risk you have for previa. multiple pregnancies, advanced maternal age, smoking, multiples, hydrops, that's fetal, large placenta, anomalies with your uterus, fibroids, African American or Asian ethnicity has been associated with increased risk of this as well. So these are, all of your ladies have some of these risk factors as well. What was I going to ask? Oh, and there can be different degrees of previa, or not previa, no, that's, yes. Increta, accreta, and percreta, and that can just be more severe cases where it starts to actually grow into the uterus and even can grow outside of the uterus, and you can have placental tissue in the abdomen and other structures in the body. So again, that's a higher risk situation than, and so if you see those on ultrasound or hear about that, that's just different degrees of previa.
Rebecca, I might just insert there that in terms of the ARS CUPS patients, that if we know that someone has a previa and it's being evaluated, and if there's ever talk about, because sometimes when you're diagnosing these things, for instance, if on ultrasound there's perhaps a suspect of something like an increta or an accreta, if you hear something like that, what it means in terms of our radar going off is that needs to be followed up on to really determine, do we have a diagnosis of something unusual like that? Because that would cause us to come together as a team and decide whether or not that patient is appropriate to be on ARS. Since if you're on ARS and pregnant, you are essentially stable obstetrically.
Right.
So
if these terms are being kind of passed around and report from day to day, it would be really smart to say, what are we doing about this, or is this okay, rather than just passing off report, oh, this is in her ultrasound, or this is being said, like, that's,
yes.
What are we doing about that? Do we have a consult, a clear plan, etc. And then some of the considerations that we need to have if you do have someone that is a known previa, but is stable, is not bleeding, any bleeding, and the take home, the next slide says this quite large, any bleeding needs to be reported. And not even with a known previa or unknown, just any vaginal bleeding, it's not normal. And it needs to be reported to provider, just keep going. But if you do know that someone has a previa, but they're found to be stable, the team decides that for right now they're stable, to consider IV access, maintaining a current hold tube for a type and screen would be in case, they can bleed at any time, and to have some of these things to be a nursing consideration might be important. And then if you are having a bleed, to save pads, save chucks, save those things. She'll probably be coming down to us quickly, but to save whatever evidence of the bleed that you have, so it can be measured, or the provider can really see how big of a bleed this was. Sometimes the manifestations of bleeding can be painless. It could be just little spots, or more continuous if it's a little bit more intense. And diagnosis is usually made by ultrasound as far as previa.
Do women who have previous histories of multiple C-sections, does that put them at higher risk for
previa?
And the evidence now clearly indicates that the more C-sections a woman has had, her risk of having one of these sort of aberrations of a placenta previa, an accreta or an increta, greatly increases with the more C-sections you've had. And those are very, very serious when you have a placenta that's grown into the uterus or all the way through to other structures in the abdomen, because you can't control the bleeding. So if they do have a bleed, it just keeps going and going. So you've got a real medical emergency on your hands. So.
And some of the reason is because of the scar tissue. So C-sections create scar tissue, and then scar tissue can create placental abnormalities for future pregnancies. Okay. Now another type of a bleeding, so placenta previa is one common bleeding situation, and placental abruption is another. And this is the detachment of part or all of the placenta from its implantation site. And it can be, observations might include sudden onset, it can be intense, it can be localized in one area, it can be painful or not really that painful, and it can be with or without vaginal bleeding. So obviously the most obvious one is if you're having bleeding, again, that would be reported. But you can also have an abruption that it's concealed, and so its placenta is pulled away at some part, and there's bleeding happening, but it's not draining, coming down and draining out. So, so that can be a little tricky when it's concealed. And we're going back. Let me go back to this one. Abruptions, sometimes they can't be seen on ultrasound. So sometimes you don't know that this has happened until after baby's delivered, and they can see that the placenta looks like it has a hematoma or something. You can tell that there was an abruption at some point. Sometimes they can be seen, and sometimes they can't. Takeaway: any amount of bleeding needs to be reported. So don't worry about, oh, well, it's just a little bit. No, call. And providers, Dr. Walsh really seconded that. He was at our second meeting, and he just said, absolutely, you call. And Dr. McLennan and Dr. Pollack also want to impress upon having a low threshold for bleeding, having a low threshold for concerns. So just, have a low threshold, and you'll be good. And factors linked with abruption. And you can see hypertension's up there, a prior abruption, prior C-section, multiple pregnancies, cocaine use, cigarette smoking, fibroids close to implantation. So your ladies have some of these as well. And then to kind of round it off, report, handoff. These are aspects of a report. If you're for general NST, yes, we want to know. It can be a truncated report. Nothing's concerning, regular. This is a normal report situation. This is helpful though, just for us to get a good full picture of her as well. But specifically, if you're transferring for cramping, for bleeding, or we're ruling out something, maybe leaking, or if there's any kind of emergency, this is happening and we need to go. These are really important things that on the OB end of things that is helpful to us to know about. I made these little cards that you can have in your badge or keep with you, and it has our unit phone number, and then it just follows subject, background, assessment, and recommendation of plan. And sometimes it can just be helpful to kind of, oh yeah, I need to know this and that. Isolation or MRSA, that's really helpful for us to know ahead of time before they come down. Any questions? And at any point, you do have questions, even just through your day, or you're questioning something, or even you're reading in a report, you don't really understand what something might mean, call us. Anyone on the OB unit can talk to you about something. We can come up and, we can troubleshoot. So use us as a resource if you feel like you just want a little bit more information on the OB side of things.
Question. You said very short umbilical cord. What would be a normal size?
With a super short umbilical cord, what that means is as the woman is in labor and this is more intrapartum, as that baby tries to descend, if there's a short cord holding him up, that would increase the risk for abruption because it would be pulling at the placenta. So that's not something you'll probably know about. It can happen more in a labor situation. And some babies have a short cord and they deliver just fine. But that's just one of the possible implications.
The only way typically you wouldn't know that unless it was noted on an ultrasound.
That's right.
So would they just say what the length is, or would they say
if there was something abnormal about the length of the cord that was visible on ultrasound, they would say there would be a sentence that told you that the umbilical cord appeared to be short.
Same thing when they say shortened cervix, less than what would be a concern?
So a normal cervical length of a long closed cervix is like 3.5 to 4. So if it says shortened, then that means that in their measurements, that it is less than that.
I have a couple of questions. One is, this hypertension, is this separate from the pregnancy, or is this,
Well, there's
I mean,
three.
if I had chronic hypertension and then got pregnant, those would be two separate things?
Well, if a woman is already, let me go back to that slide. You can see let's go back to the chronic hypertension. Yes, somebody can have high blood pressure and not be pregnant, and they get pregnant and they continue to have what would be classified as high blood pressure, 140 equal to or more than 140 for systolic, and same for diastolic is 90. That woman is at higher risk for developing preeclampsia, kind of overlaying, or for that to turn into preeclampsia where she has kidney involvement and other things.
Definition of preeclampsia, I don't know what that is.
Okay, we'll go. So this is gestational hypertension. This is, can we go back one more? So here's the sort of three subsets. Chronic hypertension already happening. Gestational hypertension, she didn't have hypertension, now she's 25 weeks pregnant and now she's having what would be classified as hypertension.
Okay.
Preeclampsia, we can go for it now, is hypertension plus proteinuria. So once she's spilling protein in her urine and she has high blood pressure, that is the definition for preeclampsia.
Thank you.
Mm-hmm. Yes.
You mentioned that one of the risk factors for preeclampsia was maternal age,
Mm-hmm.
younger, older.
You know, it looks as they age, advanced maternal age, but it's also been found in teenagers too. Like the teenager can have a higher risk for preeclampsia.
So basically the extremes,
The extremes
of like
of age.
under 18 and over 35.
35.
And then in your handouts, we added a page because when you guys were asked what you'd like to know about at this presentation, one of the things was non-stress tests and ultrasounds. And I wasn't sure if we'd have time, so I just kind of put it on as an add-on. So I think some of the CUPS nurses were like, why do our patients need all these ultrasounds every week? And it's just, what an NST does, it stands for non-stress test. We're not doing anything invasive, we just put the monitors on, and it gives us a little window into what the baby's doing. So is the baby moving? Is it well oxygenated? That basically, in a very general sense, tells us that its neurological system is intact, like the brain, brain stem is working, regulating the heart rate. We're looking for that their heartbeat changes moment to moment, and then when they move, that they raise their heartbeat. That's called an acceleration, and that's what we're looking for on the non-stress test. What happens sometimes, because the narcotics, the methadone, can suppress the baby, the variability, it basically puts the baby like into a sleep cycle. So we have to think about, okay, when is the methadone administered? When does it peak in effect? Because if you send a mom over for a non-stress test and she's on methadone and it's peaking in effect, all we're going to see is a sleepy baby that's what we call kind of flat. In other words, their heartbeat won't be changing a lot. It'll be just pretty similar. So we have to kind of think about when those are scheduled. And then sleep cycles in fetuses are normal. They're usually 20 to 30 minutes, and then they'll move around and it'll look great. If we have a mom come over and it's just not moving and we give it 20, 30, 40 minutes and we're still not seeing those accelerations, then the provider's probably going to send her for an ultrasound. And then they do those biophysical profiles, and people wanted to know what that was. So they basically look at 5 things. So the NST is part of the scoring. If they can get a maximum of 2 points. Is the baby moving? Does it have muscle tone? They actually do breathing movements in utero. They flex their lungs. And then how much fluid is in there. So if their amniotic fluid is going down, that's telling us that there could be something going on with the kidneys. There could be something going on with the placental blood flow. Because it basically, the amniotic fluid gets kind of cycled through the baby. So they swallow it and they pee it out. And it's all like a sterile, closed system. So that's just what the biophysical profile is. And if they get a low score, here's the little table of what they're looking for. But if they got a low score, then their provider would just look into more follow-up and or possibly needing to move toward delivery and then being transferred off your unit.
So the two things together, a non-stress test, and the reason it's called a non-stress test is because there is a monitoring test, oxytocin, what it used to be called the
Oxytocin
challenge test, which essentially puts the fetus under stress. Stress meaning you're having uterine contractions, and when you have uterine contractions, that interrupts blood flow. So that's putting a stress on the baby. That's what labor does. And what we want to see is, does the baby have enough oxygen reserve to make it through that temporary interruption in blood flow? So that's sort of what we're looking at in terms of stress. So it's a non-stress test because we're not doing anything to cause contractions. So that's why it's non-stress.
Right, and if a baby is not doing well without even having contractions put upon it, then that informs providers as to, this baby might not handle labor because it can't even handle just hanging out.
So, and in terms of informing your patients, when you're working with pregnant patients on cups, is reassuring them that the frequency of testing that the doctor's ordering in terms of NSTs and ultrasounds is to assure that the baby is doing well and that there aren't any signs that the baby isn't growing properly, isn't properly oxygenated, and it's just assuring us, assuming everything is well, that the pregnancy is progressing normally. So that's the information that the patient needs to have. And if something comes up on an ultrasound or a non-stress test, of course we'll be following up from an OB angle. And if they end up coming back to you, that means that things are good, because they wouldn't be returning to the unit if there was an OB problem developing that required further evaluation. So it'll help, knowing that will help you to reassure the patient that if they come back to the unit, then things are okay and we just need further surveillance, and that they need to be able to report if they have any warning symptoms, the baby not moving, decrease in movement, bleeding, leaking, those type of OB concerns.
I think a good point for patient education would be to make sure that they hear the providers bouncing words around that reactive actually means good, because in a lot of other medical tests, something that's reactive would be negative, would be a bad thing.
Correct.
Because I found that there's a lot of misunderstanding of medical terms with patients. I've had patients who, I use the word hypertension, and they think I'm talking about being extremely, extremely nervous.
Right.
And anxious. So it's really interesting sometimes, some of the terms that we just sort of take for granted.
Right.
Nobody misunderstands high blood pressure. Everybody
Right.
understands that. But I've had more than one patient, I'll say hypertension, and they'll say, yeah, I am just so nervous all the time, I can't rely, I'm stressed out.
Yeah, so you could say chronic, blood pressure before you were pregnant, blood pressure that's being now showing an increase while you're pregnant, and then blood pressure that, we need to really be careful about. So, yeah, that's great for you guys to know.
Another good word to use for a non-stress test is that it's reassuring.
Yeah,
it's reassuring us that the baby's doing well. That's another term we can use. Yeah,
a reassuring monitoring time.
Yeah.
And I think in terms too of the whole concept of ARS using OB and the OB nurses as a resource, if you have questions, you're reading something in the chart, or if the patient has questions about something that has gone on in regard to testing, that the more we hand off to each other. So if a person's coming back from an NST, and if there is time and ability for the nurses to interface for just a couple of minutes, and you can engage the patient as well to say, you had your weekly NST, everything looked great, the doctor has reviewed it, keep going, take good care of you. This is an opportunity for both nurses to interface with the patient and to engage the patient and say, things are going well, keep taking good care of yourself, especially for this patient population who's trying to obtain sobriety. You want to capitalize all the time on encouraging healthy choices and healthy behaviors for the benefit of their child. So it's a great opportunity for nursing to interface whenever time allows. Even
We're
that,
all on the same page.
yeah, that 2
Yeah.
minutes of encouraging the patient, you're doing great, your baby looks good, you know, report these things, keep drinking water,
Mhm.
you know, keeping yourself hydrated, eating well, don't skip your meals, those type of things are just these wonderful opportunities to keep reinforcing for these patients what a great choice they're making by being here and by trying to create a healthy life.